Good evening, everyone. Thanks to Conceptual Orthopedics for giving me this opportunity. So I'm working at Asian Hospital, Faridabad, Delhi NCR, and I'm Associate Director Head of Orthopedics. I do a lot of primary and revision arthroplasty surgeries. And I'll be just showing you the basics of a Varus arthritic knee. And the surgical video will demonstrate the basic surgical steps. You, as youngsters, must remember that total knee arthroplasty is a soft tissue procedure, and we are just performing the bony cuts required to put in the implant. So the key point is to manage the soft tissues. So this is a surgical video which I'll show, and it's a 27-minute video so that you can have an idea about the basic technique and how to expose and how to balance a total knee arthroplasty in a varus. It's a straightforward varus. So before you start, you must check whether the varus is correctable or not. In this case, you can see the deformity is not much and it is correctable. So I start with marking the tibial tubercle, the patella, and a midline incision would be starting almost 5 centimeters above the superior pole of patella and ending down towards the medial side of the tibial tuberosity. You mark the incision, and I usually use a medial parapatellar arthrotomy to perform. Make sure that it's central. A lot of people go towards the medial side also. That's their personal preference. But I usually do not undermine the soft tissues when I'm performing a medial arthrotomy. And with proper retraction, make sure that you have been able to expose the tendon, the patellar tendon, the medial border of the patella, and leaving at least 4 millimeters of sleeve attached to the patella. You will have to undergo the arthrotomy, and you also do the arthrotomy in the superior part, dissecting the quadriceps tendon and leaving or at least 4 to 6 millimeters on the medial side, so that when you reattach the vastus medialis obliquus, it reattaches with the tendon itself. The standard release, which we usually do in the total knee arthroplasty in a varus, is the anteromedial release. And the current concept now is to do a medial release. So we don't go all the way to the posterior medial corner initially, and we go right up to the middle of the tibial condyle on the medial side. And further releases can be done later. You release the suprapatellar pouch, you release the fat pad. Do not release whole of the fat pad because it can devascularize the patella. You can release the ACL and the PCL attachments. I'll be using a attuned PS knee in this patient. Removal of medial osteophytes is very important because they cause the tenting of the MCL, as well as do not let your distal femoral cutting jigs to be placed properly. So these release of osteophytes is important because it itself, releases the tension on the MCL and balances the varus knees. So you do a Ransal procedure where the knee is flexed and externally rotated, and the tibia can be delivered out with another Homans. And it's a very simple procedure. Once you do an external rotation and a flexion of the knee, here you can see my assistant is hyperflexing the knee, and we are able to, sublux the tibia forward. So after that, you do the soft tissue releases and release the remove the menisci. I'm using a proximal tibial cutting jig here. And you can see I'm using 3 fingers from the anterior tibial chain distally at the ankle joint, centralizing the jig in the center of the tibia. Tibialis anterior tendon attachment is another landmark which you can feel, palpate, and this will give you the anatomical axis of the tibia. You use a stylus to cut, to measure the amount of resection you need. It is usually recommended to cut 2 millimeters from the involved side, which is the medial side, and 8 millimeters, depending upon the implant you're using, from the lateral side of the tibial plateau. Once you are happy with that, you can again cross-check. You can, adjust the instrumentation accordingly so that your cut is in 90 degrees to the mechanical axis of tibia. This is very important for people who are using the proximal tibial cut technique first, because your femoral cuts are usually placed dependent upon the tibial cuts. So here you can see I put in the tibial tray here, and I'm going to perform the tibial cut. But you must see that I am cross-checking again, and I feel that it is probably cutting more. So I'm going size -2 up. So after putting it again, I will check again with the angel wing that I'm not cutting in more of the tibia. It is prudent that you do not cut too much of the proximal tibia, because as you go down, the quality of the bone deteriorates, the attachment of the collaterals is hampered, and the good quality metaphyseal bone for a good implant fixation and cementing is available at almost 8 to 10 millimeters only. So don't cut beyond that. In a severe varus knee where you will have a fixed varus, where you might need too much releases, you might need to cut in less. And it is always recommended that you do a conservative tibial cut in such situations. So you see here, I'm again checking again with the stylus that I'm not cutting too much of bone. It's 8 millimeters from the lateral side and almost 2 millimeters from the medial side. The medial side usually is sclerotic and eroded to greater extent in varus knees. Do check again and again, because this cut is very important. If you have been able to perform a tibial cut properly, I tell you 80% of your total knee arthroplasty is done. The problem lies when you're not cutting the tibial cut properly, especially if you're mechanically aligning the knees. So the other important step is that you protect the collaterals. I'm using a Homan here to protect the MCL. Another Homan is protecting the patellar tendon and the lateral structures, and the posterior Homan is protecting the vascular structures. So you start from the medial side, and gradually you can move your saw and go towards the lateral side. At the same time, having a feel that you do not go too much beyond the bony boundaries and do not try and cut the soft tissue structures. So I'm using a flat osteotome here to elevate the cut part of the proximal tibia and releasing the soft tissues starting from the posterior medial side towards the attachment of the PCL and towards the posterior lateral corner. I have been able to remove this biscuit of bone, which should be measured on with a caliper for at least few of your 100 cases